All right. Well, it's 5 after the hour, and I know we have a lot of content to get through today, so I think we can go ahead and get started. I just wanted to thank all of the attendees that made time to join us this afternoon. I know how busy everyone, especially those working in schools, are as the chaos of COVID continues to swirl around us. So I know right now, giving up even an hour of your day is a big commitment. So I thank each and every one of our attendees that made time for this webinar today. My name is Jeremy Braithwaite, and I am with an organization called EvaluAct. You'll see our logo down in the bottom right-hand corner of the screen. And we are a collaborative partner to Healthcare Integrated Services on putting together this webinar series. Healthcare Integrated Services, who I will introduce in just a little bit, will be our host and panelist for this webinar today. Just a few initial housekeeping items I'd like to go over before we get started. We are recording this webinar today, and we will make this recording available on Healthcare Integrated Services website, as well as various social media pages. Following today's webinar, we will be sending out some handouts and materials that we'll be referencing throughout the webinar. You'll hear us make reference to various websites, resources, materials. We will be emailing you a package with these materials in the next few days or so. So be on the lookout for an email from our team. And finally, after today's webinar, we will be distributing an evaluation survey. That will be coming to everybody via email tomorrow. It takes about 5 to 10 minutes to complete, and of course, we appreciate everyone's feedback as we kind of work to improve our strategy and our series over the next month. So just a little bit about what it is we're going to be doing over the next month. As I mentioned, I am with an organization called EvaluAct, which is a partner to Healthcare Integrated Services. And what we're really focused on for this webinar and this entire webinar series over the next month is to focus on transforming schools through ACEs awareness. And I'm sure everybody that received our webinar correspondence and registration materials sort of saw that as our motto and slogan of what it is we're doing. And for the past, gosh, I want to say several years, HCIS and EvaluAct have been working together in various areas of trauma-informed care, primary prevention, and really serving the needs of youth and survivors of trauma, and doing this in school-based settings, because we know that in schools, this is one of the best opportunities we have to serve students and serve their healthcare needs, particularly those underserved youth that live in medically underserved communities. They might be living in highly impoverished areas. We saw a real need to serve these populations. And so the purpose of our webinar series is to really talk about some of our experiences in that work and some of the lessons that we've learned around screening, disclosure, coordination of care, and ensuring that there's a healthy continuity of care for students that have gone through trauma. Our ultimate goal, of course, is to make sure that we're expanding our practice and really doing a better job of ensuring a healthier future for our youth. And as most of us know, doing this in a trauma-informed way. So before we get started, we did want to extend a note of appreciation to the Los Angeles County Office of Education. They have been instrumental in helping us get this webinar series off the ground. It was really because of them that we were able to get a hold of all of you that are in attendance today. Dr. Deborah Eduardo, the Los Angeles County Superintendent, Dr. Victor Thompson, the former Director of Student Support Services, and Jose Gonzalez, the Director of Community Schools Development, all played a very instrumental role in bringing this webinar series to fruition. And so we're very grateful that they were able to advocate for this webinar series and advocate for youth. So as I mentioned, this is the first of a three-part webinar series. Today we're going to be discussing issues of screening and disclosure, and the next few webinars that we'll have, we have another one coming up in 2 weeks and another one in 4 weeks. This is really a part of a continuum. So today we're going to be discussing issues around screening and disclosure of adverse childhood experiences, and subsequent webinars will build on this topic. So if you have not received registration for the other webinars, we will be resending that out. It will be a link that can be forwarded to others if you think others would be interested in joining this series. But today our focus is really that first step in the journey in terms of how do we encourage students to disclose adverse childhood events when they are experiencing them, and some of our best practices around screening. I'd like now to introduce our panel that's going to be leading us through our talk this afternoon. As I mentioned, the host of this session today is Healthcare Integrated Services. With us, we have Dr. Edna Miller, who is the founder of Healthcare Integrated Services. Dr. Miller's educational background is in criminal justice and educational psychology. Her earlier career was centered primarily in correctional rehabilitation, and she's worked in correctional institutions, parole systems, and various other agencies throughout the state of California. And it was through this work that she became acutely aware of the importance of screening, detection, and treatment of issues that start very early in childhood that bring people into the prison system. And it was really against that backdrop that Dr. Miller, in partnership with Justin Miller, founded Healthcare Integrated Services in 2004 with the goal of providing health, wellness, and life skills services to youth. And as I mentioned earlier, particularly youth who are, living in underserved and under-resourced communities. Justin Miller, the president of Healthcare Integrated Services, also joins us today. He is also the chief operating officer of Healthcare Integrated Services and responsible for all the day-to-day operations of the clinic. In 2019, Justin received an award from the California Senators and Assemblywoman's Office for dedication to students and families in the Los Angeles area. Justin is also a former McNair Scholar. We also have Dr. Bernard Hardy, who is the Chief Medical Officer of Healthcare Integrated Services. Dr. Hardy has over 35 years of clinical experience, and 20 of those years were spent in both inpatient and outpatient settings at Kaiser Permanente. We also have Chief Nurse Practitioner Amy McConnell with us. Amy has also over 35 years of experience in nursing, and she played a very integral role in the development of Healthcare Integrated Services Universal Screening Program, which received California Department of Education funding for operation. Amy's also a certified MEDI-CAL provider, as well as she also leads up a primary care unit in Santa Barbara. And finally, joining us from an organization called AmeriMed, we have Dr. Boyd Haley, who is an emeritus professor of chemistry and biochemistry. Dr. Haley has an extensive research background in the areas of mercury toxicity and neurological disease. He also has an extensive portfolio of NIH-funded research aimed at the study of all the processes involved in the flight or fight response. Dr. Haley will be speaking about that key piece a little bit later, as this is one of the important elements of the physiological response to trauma. So he'll be speaking a little bit more to that later. As you can see, we have a very, very cross-disciplinary panel that are talking about ACEs today. And so, as I said, this is a panel that represents Healthcare Integrated Services, but more importantly, this panel represents the interests of youth and survivors of trauma. And so we've got quite a full agenda for you today, but I'm going to hand it over to Justin now to kick us off.
Thank you. So first, we'd like to start with our learning objectives for this first webinar series, and that is to increase awareness about the ACEs Aware initiative, to increase understanding about the provider's role and responsibility in responding to adverse childhood experiences, to increase knowledge and of complications with youth disclosure and screening. And then we want to share our lessons learned from our frontline experience in treatment of trauma, and then apply our knowledge in our discussion of a case study today that will be presented later on in our webinar series. So with this segment, we want to really break down what exactly is the ACEs Aware initiative. And we also want to talk about what falls into the category of adverse childhood experiences. This will be presented by Dr. Miller.
ACEs is known as adverse childhood experiences. The leadership of ACEs is a statewide effort led by the Office of the California Surgeon General. The purpose is to cut adverse childhood experiences and toxic stress in half in one generation. The goal is to seek and help MEDI-CAL providers understand the importance of ACEs screening. The pioneers of this first of its kind effort is led by Dr. Nadine Burke-Harris, California Surgeon General, and Dr. Karen Mark, the Medical Director for the Department of Healthcare Services. What are the 10 ACEs? The 10 ACEs consist of abuse, which is physical, emotional, and sexual severe incidents. Incidents of neglect, which consist of physical and emotional circumstances. And household challenges, which may be mental illnesses, parent abuse, divorce. It can include incarcerated relatives and substance abuse issues. The higher the ACEs is in children or teens can lead to a greater risk of developing health occurrences, which may include diabetes, hypertension, obesity, depression, substance abuse, and sometimes attempted suicide or actual suicide incidents. Thank you.
Thank you, Dr. Miller. Next, we'd like to play a brief clip of the California Surgeon General, Dr. Nadine Burke-Harris, speaking about adverse childhood experiences and how they affect children's health.
So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems.
Great. So that was a brief but very powerful demonstration of how we can join together to better the youth health systems that are in place, especially us working within school systems. We're in a unique position to provide early interventions to youth who are possibly suffering from toxic stress caused by trauma.
So
What does ACEs Aware offer to MEDI-CAL providers? Please visit www.acesaware.org. You will find ACEs information regarding training, screening tools, and ACEs clinical protocols. If a provider would like to receive MEDI-CAL reimbursement for their ACEs screening, you must complete and become ACEs certified. We will send more information regarding this process at the end of the webinar. Who is included in the LEAs, the local education agencies, school districts, charter schools, colleges, and universities? The billing program reimburses local education agencies the federal share of the maximum allowable rate for eligible services rendered to MEDI-CAL eligible students. You must utilize the ACEs screening form called PEARLS if you would like to be reimbursed for MEDI-CAL payments. Led by Dr. Dana Long, pediatric ACEs-related life event screener was developed by pediatricians from UC San Francisco School of Medicine and the Oakland Children's Hospital. There are age-appropriate PEARLS forms for children, teen, and adults. Remember, to receive MEDI-CAL reimbursement, the PEARLS screening tool must be utilized. Thank you.
Great. So at this time, we'd just like to stop and do a quick activity just to learn a little bit more about everyone's knowledge surrounding adverse childhood experiences. We'll be utilizing a poll question format for this part of the webinar, and you'll be seeing questions pop up on your screen. We will be presenting a series of statements, and all we would like you to do is, as you hear the statements, decide if they're a truth, meaning you agree with what you're being read and what you see, or that you believe it's a myth, meaning that you believe some part of it may be false or you do not agree at all. We don't want to spend too much time on this, so please just choose the first response that comes to mind. So our first truth or myth question is, ACEs and childhood trauma are interchangeable concepts. Please respond to the poll question provided on your screen.
Like we still got some votes coming in. So if folks can just read the question that's on the screen, you should be able to select truth or myth and then submit your response. Okay, I'll go ahead and close that one out.
Mm-hmm. Okay, great. So you should see results on your screen, and these will be presented by Dr. Hardy.
Adverse childhood experiences are stressful or traumatic experiences people have by age 18 that were identified in a landmark 1998 study done on about 17,000 hydropermeability patients in San Diego and published, and has subsequently been confirmed by thousands of studies. This study also represented the 10 categories of ACEs that were developed in San Francisco and Oakland. Those categories include 3 major areas: abuse, neglect, household challenges. ACEs are types of childhood trauma, but not all childhood trauma is an adverse childhood experience. For example, death of a close family member or a physical injury or experiencing a natural disaster can be traumatic events that happen in a child's life. The key difference is that the adverse childhood experiences are more likely to overactivate the child's stress response system, wearing down the body and the brain. So the brain has a fear center that activates the hormone system, including the adrenal glands, releases adrenaline. And that impacts the immune system, which protects us from infection. In turn, that impacts the genetic material, the DNA. This overactivation is called toxic stress, which we will hear about in more detail from Dr. Haley when he speaks about the biochemistry at the cellular level. Thus, this is a myth.
Great, thank you, Dr. Hardy. Our next truth or myth statement is, tiredness is not a symptom of adverse childhood experiences. Do you believe this is a truth or a myth? Please respond to the poll presented on your screen.
Still have votes coming in, so we'll give people just another few seconds to put their responses in. Okay, I think we'll go ahead and close that.
Okay, great. You should see the results on your screen, and these will be presented by Dr. Hardy.
This statement is also a myth because one of the key defining features of adverse childhood experiences is the overactivation of the stress response system, also called the fight-flight system. This occurs when you meet something that creates fear, whether it's an animal or a person. It creates an effect that leads to a chain reaction that wears down your body from the brain all the way down to the genetic level. It is true that everyone experiences some physical and emotional tiredness or exhaustion from time to time, but be aware that sometimes this can be symptomatic of even deeper issues. Thus, this statement is a myth.
Thank you, Dr. Hardy. Great. Our next poll is, the best way to ensure physical and mental well-being is to physically heal from childhood trauma. Do you believe this is a truth or a myth? Please respond to the poll that is presented on your screen.
Mm-hmm.
Give everybody a few more seconds to put their vote in. I think we have a few people also that called into this webinar, so they won't be able to vote.
Okay, great. These results will be presented by Dr. Hardy.
Not all trauma is physical. In fact, the majority of adverse childhood experiences are not directly connected to issues of physical injury. Treating and healing from adverse childhood events requires a multidisciplinary holistic approach, inclusive of mental health, nutrition, spiritual resources, home visits, case management, and as Dr. Burke has alluded to in her video, sometimes medication. Thus, this statement is a myth.
Great. Thank you, Dr. Hardy. Our next statement is, if a student discloses that they are being bullied, immediately stopping future bullying occurrences is the most important priority. Do you believe that this statement is a truth or a myth? Please respond to the poll presented on your screen.
Okay.
Okay, great. The results will be presented by Dr. Hardy.
Now, this statement is a tricky one. Children who have emotional health and well-being issues, such as depression, are generally more likely to experience bullying victimization than children who do not have emotional issues. It is possible that emotional issues in children are symptomatic of underlying trauma, including adverse childhood experiences. This does not mean that all children who are bullied are experiencing adverse childhood experiences. But students who are victims of bullying may require special attention beyond simply putting a stop to future bullying occurrences. Thus, this statement is also a myth.
Great. Thank you, Dr. Hardy. It truly is great to see where everyone is thinking and their current thoughts surrounding ACEs and the core issues around adverse childhood experiences. Thank you so much for your participation. As you were going through these, you probably felt that some parts were a myth, and you probably felt that other parts were a truth. And so it wasn't typically black or white. That was intentional to just demonstrate just how complex these issues of adverse childhood experiences truly are. What we know about adverse childhood experiences is rapidly evolving every day. And after this webinar series, we hope that you'll be able to pass on some of what you're learning to your colleagues. For now, we're going to talk about the sciences of ACEs and toxic stress, presented by Dr. Boyd Haley.
Yes, I have a complex issue of explaining the science of ACEs and toxic stress and how it affects children. When the phrase adverse childhood experiences is mentioned, people automatically and mostly correctly assume that this has to do with in terms of emotional and mental health. Many of the ACEs have significant psychological consequences, and there's a tendency to think that these are issues are best addressed by therapists and mental health practitioners. But it is extremely important to recognize that the impact of ACEs and toxic stress extend well beyond our minds and impact our bodies at the cellular and molecular levels, involving biochemistry of the body and health. ACEs increase fear, which causes an immediate and massive increase in the production of ATP. ACEs decreases the level of glycogen storage that is used to make this ATP, and so multiple ACE events can deplete the body of the glycogen needed later on when they need it for learning or healing, etc. The biochemistry of adrenaline is well known. It's usually in the very first chapters of a biochemistry textbook. It causes the breakdown of the cellular energy stores of glycogen into glucose that is taken through the metabolic pathways of glycogen and the citric acid cycle to produce maximum amounts of ATP for increased energy required to fight or run. Multiple ACE events to a child on a daily basis or weekly basis can deplete that child of the mental energy, the glycogen stores that he needs to handle major fear and trauma. Analogy, when a child is exposed to an adverse childhood experience, for example, physical abuse or seeing a parent experiencing domestic violence, the physical response to that trauma is quite similar to that of a soldier in combat. I mean, they make a lot of ATP and they burn out. ACEs and oxidative stress susceptibility. ACEs can cause depletion of the glycogen stores that diminish later fight or flight responses. An example of this, when you see someone that you say he's burned out or he's suffering from post-traumatic stress syndrome, and several other events that you find with people that have been put under a tremendous amount of stress multiple times in their life. If this happens to a child, it can have major effects on them because it can deplete their body of the ability to make ATP in certain compartments where it's exceptionally needed. And one example that I'd like to talk about is ATP is needed for the body to synthesize reduced glutathione, GSH. GSH is a major antioxidant and toxin protective compound that the body needs that has decreased the effects of toxic exposure. For example, GSH is responsible for removing toxic mercury, cadmium, and other metals like arsenic from the body. If you don't have GSH and you're exposed to these toxins, which we have just seen in a recent report, that baby food, 86% of the baby food in this country contain roughly 10 times more toxic mercury, cadmium, and arsenic than the FDA or the CDC recommends in food. And GSH is also responsible for protection against oxidative stress at the cellular level to prevent illness and death. Repeated ACEs leave children more vulnerable to physical and social difficulties in adulthood because it decreases the level of this very critical compound called glutathione or GSH in your body. My research in the last 10 years has been dedicated toward making, we have it in FDA evaluation in the final stages right now, a drug that mimics glutathione by binding to and eliminating much of the toxicity that glutathione binds to and eliminates. That's all.
Thank you, Dr. Haley. Next, we'd like to go into a segment on where we share how we screened for ACEs in our primary healthcare clinic. So within 2019, we began screening for ACEs using our universal health screening tool at our primary healthcare clinic that is directly on high school campus. Each student received a self-assessment tool as well as their ACEs screening, as long as their parents did not opt them out from receiving the beneficial service. During student orientation, we explained the purpose and importance of the self-assessment tool and how it would benefit each student and prevent trauma from occurring later on. HCIS emphasized that the information was confidential for each individual student unless the student endorsed harm to themselves or to others, or a clinician had concerns about reported child abuse. After each universal screening was completed, HCIS made sure to thank each student because we understand the difficulty that goes into disclosing past or newly revealed trauma. Next, we're going to break down what exactly is trauma screening, what goes into it, and a few experiences learned from our direct hands-on primary health care clinic.
So what is trauma screening? Trauma screening refers to a tool. For instance, we use the PEARLS, which is the Pediatric ACEs and Related Life Events tool, and a history and physical for adolescents. It focuses inquiry to determine whether an individual has experienced one or more traumatic events, has reactions to such events, because they don't always, and has specific mental or behavioral health needs and or needs a referral for comprehensive trauma-informed mental health services. Why is screening for trauma important? Universal screening for trauma history and trauma-related symptoms can help behavioral health practitioners identify individuals at risk of developing more pervasive and severe symptoms of traumatic stress. I like to see this as, if you don't ask, you won't find out. And students don't always have to answer in the affirmative, but again, if you don't ask, you may not ever find out. How do you ask a child about trauma? In the milieu of, in the setting of a private exam room, you ensure that the child understands that everything that we talk about is absolutely confidential. It doesn't leave the clinic, and that they can choose to talk about these experiences and to provide as little or as much detail as they want. We clearly communicate the reasons for asking about past trauma. For example, I always tell students that I'm seeing every student and I ask every student the same questions because I want everybody to be healthy and happy.
Thank you. So next we're going to go into a segment about youth disclosure and screening and what practices help facilitate a youth to open up and disclose their trauma.
Things to know about student disclosure. It's not always an event, but it's often a process. So disclosure may not happen in the first assessment, but what does hopefully happen in that first assessment is that you lay the groundwork for trust and building rapport so that they know that we're there for them. Following the ACEs model, you should conduct periodic screening since exposure may occur after the initial screening and throughout the years of adolescent experience. Students often return to us throughout the year with more information or new information, things that they want to discuss. You should verify reported ACEs with the student in a comfortable and confidential setting with trained medical personnel. These steps will provide a sense of care and trust. I can't emphasize enough how important it is to establish that confidential and trusting rapport. Students may have an emergency. In these cases, follow up with a behavioral specialist and/or a medical doctor or provider to identify underlying health conditions and/or trauma symptoms flagged as high intensity during the initial screening, such as suicidality or nightmares, flashbacks to earlier insults. Students reporting emergencies to you is a sign that the initial screening built rapport. There's a code phrase that students can use that the teachers understand, and they say, I have an appointment in the clinic, which means that they will be released to come to talk to us whether or not they have an appointment. They know, and teachers understand that that means that there's a critical issue going on and the students need to talk to us. Sometimes parents or caretakers completing the ACEs screening tool for younger children are the abusers. Sometimes parents and caretakers will try to withdraw completed assessments once ACEs are uncovered. We've seen that a few times. A family system will try to maintain homeostasis in their dysfunction at all costs. And often what we see are the students who are suffering because they've had years of not being allowed to talk about issues that are going on or that have happened. It's challenging when parents give us a lot of pushback about something that the child reported to us, and the parents don't want to disrupt what's working for them, but the bottom line is it's not working for the student and it needs to be addressed.
Absolutely, great. So in this segment, we're going to be discussing lessons learned throughout our universal screening practice, some issues we've had and how we've addressed them and moved forward to benefit the youth. So one of the issues we had was when healthcare integrated services attempted to distribute parent information and consent letters so that the parents would become aware of the beneficial services and ACEs screening awarded to their children. Unfortunately, the issue faced was that the parent consent letters were not being returned to the clinic, and oftentimes we found that the parent never even knew the clinic existed on campus or that the student could receive these beneficial services. And the cause of that was for a number of reasons, such as the student could have forgotten simply to turn in their parent consent form to their parent or guardian, and it just stayed in their backpack, crumpled up, never to be seen again. Another issue we found was that students, when they got their parent consent forms back from their parents, they then felt like they didn't want their parents involved in their medical care or felt like their confidentiality might be violated at some time. And so they felt that they needed to hide the parent consent forms to protect their own confidentiality. Another issue was simply that the parents signed the consent form and the student simply forgot to return it back to the clinic. So we realized that there needed to be a point of access to provide parents with the direct knowledge on what exactly is adverse childhood experiences, how does ACEs affect their academic performance, and what are the benefits to early ACEs intervention. And so to facilitate that, we found that working with parent coordinators directly on campus or working with the district really helped facilitate getting that information to the parent and getting the parent consent forms back to the clinic. We would host parent nights within the clinic with the parent coordinator's help to relay information directly to the parents. We would attend school events so that the parents could receive information about the beneficial adverse childhood experiences. And so working with parent coordinators was really, really key into getting the youth the beneficial ACEs screening.
Other issues and lessons learned. The issue, sometimes students may incorrectly report during their screening due to language barriers, undocumented IEPs, or misinterpretation of assessment questions. Lessons learned: to ensure students properly understand the questions, use tablets and electronic health records. Also, parents of IEP students should be required to complete all consent forms prior to student assessments. So for instance, one of the questions on our questionnaire was, have you ever carried a weapon to school, such as a gun or knife? And occasionally students will just in error mark the wrong box. Everybody that has a flag found on the assessment tool is brought back in for one-on-one conversation. So whether or not the student is carrying a knife because they feel like they're in danger and they need protection, we see that often. They may then say, oh no, I carry it to peel fruit. That may or may not be true, but it gives us an opportunity to explore the issues with kids and say, you know, if somebody were to, you know, that may be true, but if that knife were to fall out of your backpack, what might happen? What are some of the consequences long-term if you're seen with that? You know, how can that impact your experience here at school?
Issue: facilitation of screenings for special education children or teens are oftentimes a challenge within school districts or other institutions. Some school districts have a rule that special education students are barred from being screened. Lessons learned: there are many special education students who also present with ACEs and whom would benefit from ACEs screening. So what we have learned over the years, we developed special protocols to work with the education system. When screening special education students, we make certain that it includes an interdisciplinary treatment meeting that may be with education staff, other leadership staff, including principals, and most importantly, parents or guardians. Additionally, we learn to work with our behavioral health specialists to do upfront inquiries. There may be oftentimes situations where there's a child abuse report that is with protective services or other information that is with social services or mental health agencies. So it is always a good idea to do a thorough research on all students, but especially students that are identified with IEP. And in some instances, we found the causes of their ACEs needed a new IEP to be developed on students who were never classified as IEP. Thank you.
Thank you. So at this time, we'd like to turn to another brief activity just to demonstrate how this all looks of screening disclosure within the actual practice. Throughout this webinar series, we'll be presenting an ongoing case study that demonstrates how healthcare integrated services had detected, addressed, and followed through with cases involving ACEs impacted youth. This is a brief disclaimer that I would like to mention that we are presenting this case study, as well as throughout the rest of our webinar series, will not be based on one particular patient's experiences. Instead, we've created a synthetic case study informed by our experiences over the past 20 years. I do want to point out, though, even though this fictional case study is a work of fiction, you should not think of this scenario as unrealistic.
So a 16-year-old female patient is seen by her school site primary provider to request a pregnancy test. Happens often. Patient completes intake and minor consent, a routine trauma questionnaire, and a self-assessment. She reports decreases in her grades and increased absences. Also, she reports thoughts of suicide, isolation, and sadness in the past 6 months. She also reported feeling unsafe at school.
Great, so please take a moment to take this in and digest it a little bit, because in our next segment, we're going to have an open discussion, and we please urge everyone who feels comfortable to participate with our panelists today. So in this section, we'll be discussing our case study that we presented. And here are some talking points. Would your district or school site have a safe space to help the patient report her ACEs? And based on your district's policies and procedures, how would you approach this case? So at this time, we're going to open up the audience to participate with our panelists in our discussion. So nurse practitioner, Amy McConnell, how would you, in your experiences, what safe spaces helped a patient report their ACEs?
Again, ensuring confidentiality, assuring them that they're certainly not the first time that they're certainly not the first patient or the first student who's gone through these things, and that there's help and trusted adults available.
Okay, great. Are there any other thoughts on this case study?
Yes. Oftentimes, we provide an orientation for students. And in this group orientation, we show a video that reveals students coming forward to report various incidents of ACEs in their life or different incidents of ACEs. And then we provide a private space for the students to take the universal screening process on a computer, so their answers are private, and they're able to think and have a safe space to just reveal things that they may have not revealed in over 10 years. And we found this system does work. Students do reveal unexpectedly. They reveal oftentimes more often than we have expected. And this provides an outlet for us to begin getting the students the help that they need. If it's some type of emergency incident, we do bring the student in and let them know if there's something involving criminal issues or their health issues, that we could no longer keep it confidential. We do talk to the student first if it elevates to another level, to make that student feel safe and to let the student know that we are there and we have practitioners to help them in their life, and we have referrals to send them to other areas and other agencies that can further explore and help them begin to heal and have academic success.
And I just put in the chat if everybody should be able to take themselves off mute if they'd like to offer some of their own experience. You can also use the chat if you would like to. So if anybody wants to be the first brave one to bare their soul, please feel free.
I'd like to add that occasionally students I'll directly ask them questions and they'll answer, you know, in a very closed way, but they may come back and talk to the medical assistant and really divulge and really open up, in which case then they come back in front of me with the medical assistant, and they feel much more comfortable in discussing these sensitive issues if they've already talked about it with somebody that they feel more comfortable with, perhaps somebody who's closer to their own age.
I like to agree with piggyback on what you said. I'm a male provider, and sometimes a female may have a issue with a male at home, but the medical assistants are well trained, and like Amy said, they know that if it's something like that, they'll probably take that to Amy as opposed to me, and vice versa. If it's a male who doesn't want a woman to know he's embarrassed by something, we have trained the medical assistants to triage this, and sometimes bring them along with them, makes them feel more comfortable, like she said. So yeah, we adapt to the situation based on what the patient's needs are. Thank you.
It's also worthwhile to mention that we can bring students back. They may tell you a tiny piece of the puzzle, and then you ask them if they, you know, you can say, I'd really like to see you, I'd really like to talk about this again. You know, I'm going to check back in. Do you think a week or 2 weeks and we can see you again? And they will, and pretty soon you'll get the whole story, or a lot of it. But that consistency is and our availability is really a unique part of our program, and it's a wonderful opportunity to make a difference.
Absolutely, absolutely.
Also,
Go ahead. I would like to share one other occurrences that I have found in working with Chief Practitioner Amy McConnell. Sometimes, oftentimes more than not, students will bring up conditions or trauma experiences that their siblings have had, not necessarily themselves, but they do feel comfortable coming in to the clinic in private settings and asking for help with their friends and other family members. And we have found by having the school clinic on site has provided a safe space for the students to share. They may not share right away, but taking the initial screening for pearls or the universal screening, they may think about it and come back later on. But eventually we have found that we do get a widespread of students that do reveal and come in for help. Go ahead, Dr. Hardy.
this is along the same lines of what you and Amy said. I have been medical director of clinics that are catered towards students, both in Alabama in the rural South, and I've been in clinics at Kaiser, and I've also been over clinics in the LA County system, but I won't call them names. But the problem with them is that they're doing so many things that they're trying to rush people through. It's more of a cattle call, I would say. It's so busy that there's no time to sit still and allow privacy and the safe space. So I think that what makes this clinic unique from anything I've ever seen is that we don't rush them. They have privacy. They're not a number. There's not a 10-minute or 5-minute thing. If you go to urgent care, they're busy. The doctor's in and out, in and out. And that unrushed, safe space, variety of providers, the medical assistants are not rushed, that changes the whole ballgame and makes it more amenable to their sharing. So that's it. Thank you.
I'd like to mention our lunch bunch too. One thing that we found is pretty pervasive is that the kind of the theme of loneliness amongst our students. Some of them really feel quite isolated. And so we've had, over the past years, invited students to come in and spend their lunchtime with us and with each other. And And they have turned into a sort of a support group run by themselves, by their peers. And it really has allowed some of the students to shine. It's really quite miraculous. We are mostly hands off on that, and they kind of run it, and they meet each other's needs, social needs, guidance needs from peers.
If we do not have any more questions, I would like to close the chat line by saying, please follow your district policies and protocols that has been established for trauma. We do work very closely with Los Angeles County Office of Education. I know that LACO has a very, very comprehensive trauma process, a very extensive, well-ran policy and protocol procedures. So please follow your district's policies and procedures that they have in place.
Thank you, Dr. Miller.
So we talked about our case study. This again is a fictional character, but the events and the issues are very real and very common. Once the patient consented to screening, the patient received universal screening through the PEARL. That's the Pediatric Adverse and Related Life Events screening tool. In her screening, the patient reported that she has been repeatedly threatened and bullied by a popular male student, as well as having experienced various forms of violence. The patient revealed that she's been sexually attacked, raped in the girls' bathroom, and pressured to continue to engage in sexual acts ongoing for the last 6 months. Urinalysis pregnancy screen was positive. In our next webinar, we will discuss how we coordinated care for this student. Please join us.
Right, so that concludes our concludes our content and webinar for today. And as Amy had mentioned, this is, and as I mentioned earlier, we will be continuing this case study and this webinar series in the coming weeks. So we are, we can go to the next slide. So just as a reminder, there are going to be some emails that are coming your way in the next couple of days. First and foremost, that evaluation that we had mentioned, everybody's going to be getting a SurveyMonkey link tomorrow. Please, if you have time, please give us some feedback on that. It should take anywhere from 5 to 10 minutes, not too long. Again, I understand that time is limited and precious in the climate we're in right now, but your feedback we do take very seriously in terms of making our webinars better. So we would appreciate any time you can put into that. We also, as I had mentioned earlier, have our second webinar kicking off on Thursday, February 25th. So not next Thursday, but the Thursday after. If you have not yet registered, we will put the link, registration link in the chat right now. And please feel free to forward that link to others that you think would benefit from attending that webinar. As Amy mentioned, that will be a webinar that's focused on coordination of care. Just our contact information, if you are interested in learning more about the ACEs Aware initiative, I encourage you to visit their website at acesaware.org. Healthcare Integrated Services website is also available right there. And as we had mentioned earlier, we will be sending you all this information via email following today's webinar in the next couple of days. And I'm going to turn it over to Dr. Miller just to close us out this afternoon.
Yes, thank you for your attendance. We have a very unique healthcare school-based health approach. If you would like to learn more or receive a presentation about bringing healthcare services to your campus, we are licensed in Los Angeles County, and we have the ability of serving all of Los Angeles County. If you're also interested in learning how to conduct the ACEs screening through MEDI-CAL providership, we will be happy to do a presentation and help you one-on-one with those services as well. Thank you kindly.
All right. Thank you, everybody. That concludes this installment of our webinar series. We hope to see you in a couple of weeks. Thank you so much for making time for this today.